So good morning. My name is Mark Robson. I am the Chief of the Breast Medicine Service at Sloan Kettering, Memorial Sloan Kettering in New York. And my assignment today is to talk about updates in basically inherited breast cancer. There wasn't a whole lot at San Antonio about this, but there has been a lot going on. So I'm going to review some new information and hopefully give you some updates. These are my disclosures. None of them are actually relevant to what we're doing today, and most of them now are uncompensated since I took my current position. So trying to move forward. There we go. So this is me. That's my email and that's my Twitter handle. So please feel free to hit me up if there are any questions later on. Happy to answer anything at a later time. So this is a distribution of breast cancer risk in the general population. And of course, the median relative risk is 1, or the mean relative risk is 1, because that's the average risk. But there is a wide distribution of risk. As a matter of fact, people at the upper end of the distribution have about 2.5 times the risk of those in the mean, and those at the lower end have less than half the risk. So the question is, what is it that causes individual risk to fall at some point along this continuum? And we know that there are a number of different sources of variation. There are factors that are intrinsic to the individual, such as reproductive risk factors, breastfeeding, perhaps alcohol, obesity, things that we know about. Environmental exposures, I mentioned alcohol, that being the biggest one, but hormone replacement therapy, et cetera, et cetera. And then what we're going to spend most of our time today talking about is inherited factors. So the hereditability of breast cancer risk is something that has been the source of intensive investigation really for the last 25 years now. And what we have learned is that there is a certain architecture of inherited breast cancer risk. This is a diagram that's repeated in various forms time and again. But basically, there are rare genetic variants, such as BRCA1 and BRCA2 mutations, which have a high penetrance. In other words, are associated with a very high relative risk compared to the average population. And then there are moderate risk variants, relative risks conventionally assigned between 2 and 5. They're also quite rare, but in aggregate are about as common as the high penetrance variants. These are things like ATM mutations, CHEK2 alterations, PALB2 alterations, and there's a lot to be said about them, and we actually will touch on them a little bit later on. But for now, we're going to put them to one side, because what I want to spend most of the time talking about is the impact of common variants. And these are the constituents of so-called polygenic risk. Common variants are different than the moderate and the high penetrance rare variants. The moderate and the high penetrance rare variants generally impair the function of a specific gene, whereas the common variants were identified through genome-wide association studies. And what they are is they are different forms or different alleles at a particular locus, a particular site in the genome. And these are not usually functionally significant, or at least not known to be functionally significant. And as a matter of fact, many of these are present in non-coding regions of the genome. And why these influence risk is still not completely worked out, although it does appear that they influence the expression of genes which may be involved in proliferation or other factors associated with increased risk. And so they are influencers, and sometimes influencers at quite a distance. But whatever the cause is of their influence, it's known that there are many of these that are associated with both hormone receptor positive and hormone receptor negative disease in the general population. So a couple of comments. One is that, as you can see, there are a lot of these. And as a matter of fact, there are at least 313 single nucleotide polymorphisms that are associated with breast cancer. That many of them are pretty common in the general population. Down at the bottom, this is allele frequency. And so you can see that some of these, the high risk allele is present in up to 80% of the population studied, sometimes even closer to 95% of the population being studied. But the individual risk associated with each of these variants is quite small. So down in the neighborhood of between 1 and 1.4, and most of them are shorter, less than 1.2, and many of them are between 1 and 1.10. So very, very minuscule effects on risk. Interestingly, there are fewer of these that are associated with hormone receptor negative disease, but there still are quite a few. And for most of these, the risks are also extremely low. Now, individually, genotyping for any one of these sites is not particularly helpful, but it turns out that their contributions to risk are independent, and they can be aggregated into a so-called polygenic risk score. And this is just the arithmetic calculation that allows you to generate a polygenic risk score. And basically what it is, it's the odds ratio at a particular locus for the allele multiplied by the number of alleles. And then those are all added up. And because they're independent, it's called log additive or multiplicative combination. So essentially, you're just looking at an individual, and at each of those 313 sites, seeing do they have 0, 1, or 2 forms of the risk allele, and then multiplying that times the weight, and then adding those all together across the whole 313 loci. When you generate a polygenic risk score in this way, it is clearly associated with risk. So this is from the Breast Cancer Association Consortium. These data are now old, looking at the association of polygenic risk with breast cancer in a group of nearly 34,000 cases and 34,000 controls, all of which are European, a point to which I will come back later. And what you can see is that the mean polygenic risk score is highly statistically significantly higher in cases than in controls. And the risk curve, which is the same form of what I showed you at the very beginning of the chat, is shifted to the right, shifted higher than it is in the controls. So this is mathematically incontrovertible. Now, the other point I'll make, though, is that there's a tremendous amount of overlap in the polygenic risk between those who are cases and those who are controls. Polygenic risk is, to some extent, linked to, but distinct from, family history. If you think about it, these are 313 loci that are all segregating independently. And so this does not move through a family like a Mendelian predisposition. There probably is at least some sharing among first-degree, well, there is sharing among first-degree relatives, but the further away the relative is, the more the polygenic risk is modified by the addition of loci from the other side of the family. This is very, very different than how autosomal dominant risk works. But in general, because there is some inheritance of the risk alleles, you can see that the family history is partly explained, particularly in older women, by polygenic risk, but only between 12 and 14%. So the majority of risk associated with family history, particularly in young women, is not explained by polygenic risk. And we're still trying to figure out exactly what the missing hereditability actually is. Now, I showed you that there's a lot of overlap between the polygenic risk scores of cases and the polygenic risk scores of controls. So in the clinical setting, how do we assess performance of a polygenic risk in predicting an individual's risk? And the core concept here is something called discriminatory accuracy, which is measured by something called the C statistic. And what that is basically if you have a mixture of cases and controls, blues and greens here, the C statistic is the probability that a randomly selected case will have a higher polygenic risk than a randomly selected control, which is the same thing as the area under the curve of a ROC, receiver operating curve. And the C statistic for polygenic risk in the European ancestry population is about 0.622, which means that 62% of the time when you pick a case, you're going to have a higher PRS than a control. That is not great. It's better than the 50-50, which is what it would be if it was completely random, but still it's not particularly high. And it is still, though, higher than that's associated with some of the empiric risk models, particularly, for instance, the Gale model. Another way of looking at this is what's the odds ratio at a given percentile of polygenic risk score. And this is a little bit more interesting because if you look at the sort of central tendency of polygenic risk and assign it an odds ratio of 1, women who are in the 95th to 99th percentile have 2.5 to 3.5 times risk compared to those that are in the middle. And women who are at the bottom percentiles have less than half the risk of those who are in the average. So although there are not particularly many people in these extreme distribution parts of the distribution, the upper and lower percentiles, the differences in risk in these people are meaningful. They're more meaningful than what we see with many other empiric risk factors. Now, whether or not this is useful in a clinical sense is something that we can debate. There are some who have argued that if you can identify women in the lower part of the polygenic risk distribution, that perhaps these people would be suitable for less intensive screening. Whether or not those in the upper part of the distribution require more intensive screening depends, of course, on what the thresholds are for employing things like MRIs. One place where there may be some immediate application to polygenic risk scores, though, is that they do modify the risks that are associated with rare variants. So in other words, if you have a woman who has a pathogenic or likely pathogenic mutation in a gene like CHEK2, ATM, PALB2, even BRCA1 and BRCA2, those who have a higher polygenic risk score are going to have a higher risk than those who have a low polygenic risk score. In the high penetrance predispositions like BRCA1 and BRCA2, this doesn't particularly move the needle. We're doing a study right now offering women polygenic risk modified estimates and seeing whether or not it changes their perspectives on things like prophylactic surgery. And so far, our experience has been that the degree of movement within the center of the distribution is not enough to really impact people. But when you start applying this to less strong predispositions, for instance, CHEK2 or ATM, where the baseline risk is about 2 to 2.5 times the general population, the average risk associated with the CHEK2 alteration, which is indicated by this red line. When you start applying the polygenic risk score, now the distribution widens out quite a lot and widens out in clinically significant ways. So the yellow curve here is what the distribution of risk would be if you only used polygenic risk scores to modify your CHEK2 risk estimates. And the blue is a curve that comes from the aggregation of traditional risk factors, mammographic density, and polygenic risk. And what you can see now is that a very substantial proportion of women with pathogenic CHEK2 alterations, even if they have a family history, would be predicted to have a lifetime breast cancer risk less than that of the general population, which is that indicated by the purple line. And even if there's a family history, many women with a CHEK2 alteration will have a lifetime risk that is less than the 20% threshold that's used for the US MRI screening guidelines. And if you're using the European 30% screening guidelines, more than half of them will be below that risk. So polygenic risk modification of moderate penetrance could be a very important way to help women make decisions about risk management. This is a study that was published by the Myriad group. I took part in this study looking at, again, the use of polygenic risk and other factors to assess the impact on moderate penetrance genes in a clinical sample. And again, you can see for CHEK2, roughly half of the patients have a less than 20% risk. For ATM, it's a little bit less than that. But for the higher penetrance genes like PALB2, BRCA1, and BRCA2, the risk did not necessarily move low enough to have a clinical impact, certainly not on screening recommendations. So this has been validated now in a couple of data sets. And indeed, this is a third data set just emphasizing this. And this is from the NCI group, showing that if you apply polygenic risk modification to patients with moderate penetrance variants like CHEK2, ATM, BARD1, what you find is that for check 2, for instance, 30% of women with no family history and 10% of those with a family history have a less than 20% lifetime risk. For ATM, it's about 45% and about 20%. And for BARD1, really 65%, nearly 70% of women have a less than 20% lifetime risk. And it's even 40%, even if they have a family history. So again, applying polygenic risk modifiers to moderate penetrance risk estimates could be enormously helpful in the future. Now, in the general population, the question is, can you apply polygenic risk and aggregate it along with empiric risk models like Tyrer-Cuzick, Bodicea, Myriad model? And there have been a lot of ongoing attempts to do this, to generate a so-called integrated absolute risk prediction, taking into account multiple possible factors. This, again, is some work done by the Myriad group. Similar work has been done by the Cambridge group, showing that if you integrate the polygenic risk score with, in this case, the IBIS or Tyrer-Cuzick model, you can identify a group of about 33% of patients who have a greater than 20% lifetime risk, and a small, less than 0.5% group of patients who actually have a lifetime risk of greater than 50%. And this, again, seems to track pretty closely with the Tyrer-Cuzick risk, but there is this subset of patients who are higher with the polygenic risk, with the aggregated model than with Tyrer-Cuzick alone. And if you look at a 2x2 table of this, what you find is that although both models identify similar numbers of patients or similar proportions of patients at high risk, low risk, or increased risk, what you see is that there is some reclassification. So about 10.5% of patients that are identified as being at greater than 20% lifetime risk by Tyrer-Cuzick are actually identified at low risk once you incorporate polygenic risk modification, and about 8% of the patients who are thought to be low risk by Tyrer-Cuzick are actually at increased risk by the combined model. So this begs the question of whether or not it's true. And this is the big problem, because so far everything is mathematical. It all should be true, but the kind of gold standard for demonstrating that it is true is observing in a cohort, preferably a prospective cohort, whether or not the combined model is calibrated in the sense of, do you see the predicted number of cancers when you have the model applied? This type of calibration has been done with empiric risk models like both Tyrer-Cuzick and the Cambridge model, which is called Bodicea. And in both of these, using various data sets, it's been shown that in a group of patients who are assigned a particular risk, and in this case it's by quartiles, the average risk of the quartile is actually pretty close to the observed average predicted risk, is pretty close to the actual average observed risk in terms of the number of cases that are seen in that quartile. So this is taken as evidence that the models are calibrated and therefore applicable to patients. This kind of direct type of calibration has not been shown for the combined models yet, although there are certainly a number of studies underway, but there is at least circumstantial evidence that this is true. And this is by essentially matching up the combined models against the already established models. So in this case, again, this is using the Myriad combined risk score and comparing it to the Tyrer-Cuzick score. And what you see is that within each age group here, the average predicted risk from Tyrer-Cuzick is essentially exactly the same as the average predicted risk from the combined risk score. So what this should tell you is that if Tyrer-Cuzick is calibrated, the combined risk score will be calibrated. We still can't dive into whether or not individual risk predictions are correct, because there's no such thing for an individual as an observed versus expected ratio. There's a certain percentage of probability that they'll get a cancer, and then it's either 0 to 1. So their O to E is either 0 or 1. And that just isn't something that you can prove in a mathematical way to be accurate. So to summarize all of this, which I know I've gone through very, very quickly, I think it's important to understand that polygenic risk is not theoretical. This is no more theoretical than what we observe for rare variants. It only accounts for a fraction of familial risk, and it's really probably most clinically meaningful at the tails of the distribution, at the higher and lower percentiles. I think its immediate clinical utility will probably be in the setting of moderate penetrance genes, people who have rare variants in moderate penetrance genes. And combinations with empiric models like Tyrer-Cuzick or Bodicea are completely feasible, do result in some reclassification compared to what is seen with those empiric models. And at least as far as we can tell, should be well calibrated, although we're still waiting for complete studies to show that. It is awkward because some of these people do have high predicted risks, despite what sometimes are pretty limited family histories. And that can be a very, very difficult thing, both for us to accept and indeed to communicate to the patients with an appropriate recognition of uncertainty. There are some limitations. One is that most of the polygenic risk information has been derived from studies that are heavily weighted towards European ascertainments. There are a number of attempts to adjust for this and incorporate other ancestries. And indeed, again, one of the commercial diagnostic laboratories has been doing this through their own data sets and now is doing an adjustment. And there was a presentation about that at San Antonio. And certainly the academic laboratories are trying to demonstrate that the polygenic risk is applicable across ancestries. And I think the general answer is that it probably will be, particularly at the extremes of the distribution, although it may be shifted a little bit one way or the other when it comes to the means. Calibration for all of these in terms of observed versus expected is inferred, and inferred on the basis of some pretty strong evidence, but it's not absolutely proven yet. So now I'm going to completely shift gears because Dr. Sharma asked me to talk about another aspect of genetics that's important in 2022, and that is the issue of adjuvant PARP inhibitors and how they influence our genetic testing strategies. And the thing that has really driven this, of course, has been the Olympia trial, which was presented at ASCO this year, in which individuals who had pathogenic or likely pathogenic germline alterations in PRCA1 or BRCA2, HER2 negative early stage breast cancer, who either had T2 or N1 triple negative or 4-node positive ER positive in the postoperative adjuvant setting, or who had residual triple negative after neoadjuvant chemotherapy, or residual ER positive of fairly substantial extent. And these women completed 1 year of adjuvant olaparib after getting all their local therapy and conventional systemic therapy. And what was published in the New England Journal was substantial improvements in invasive disease-free survival and distant disease-free survival, with a strong trend towards overall survival improvement. So in my opinion, for the clinical trial population, this is now a standard of care. So the question becomes, how do you go about identifying the individuals who should be getting this? And the challenge is that the conventional NCCN criteria, which is what we use in the US, are a little bit insensitive for the detection of pathogenic variants in germline predisposition genes. And this was first brought up by Peter Beige, who was doing a study in combination with one of the diagnostic laboratories in Vitae. And in a reasonable size sample, what they said was, look, there's a lot of pathogenic variants in patients who did not meet NCCN criteria. But what I will point out is that most of the incremental yield was in genes other than BRCA1, BRCA2, or traditional breast and ovarian cancer predisposition genes. And indeed, for BRCA1 and BRCA2, it was relatively sensitive. These are similar data from a larger data set from the Mayo Clinic, Sid Yadav and Fergus Couch. And again, what you can see is that in patients who do not meet NCCN criteria, you do actually identify alterations in about 3.5% of those patients. But most of the pickup in BRCA1, BRCA2 is seen within the NCCN criteria meeting patients. There's a relatively small incremental yield beyond that. Now, if you just stick to NCCN criteria or under the age of 65, you pick up 98% of the BRCA mutations and 95% of the high-risk genes. And so most of the incremental yield in the older women is actually in moderate penetrance genes. So if you restricted it to under 65, you'd see most of them. When you roll in PALB2, it gets a little bit more complicated. The NCCN criteria are about 82 to 83% sensitive for the detection of BRCA1, BRCA2, and PALB2. If you increased age, it would probably get significantly higher. But the incremental yield from testing all patients with breast cancer for these three genes is about 0.36 to 0.42%, so up to 1 in 250. If a number needed to test of 250 is appropriate in order to identify those who are going to benefit from adjuvant PARP inhibitor or PARP inhibitor in the metastatic setting, then this is a reasonable thing to do. If we want to be a little bit more constrained, then I think leaving it at the age of 65 is probably reasonable. Majority of the incremental yield in a strategy of testing everybody is actually in genes other than BRCA1, BRCA2, and whether or not that has any clinical utility is uncertain because those genes don't confer sensitivity to PARP inhibition. So to summarize that whirlwind tour, Olympiad, Embraca, and now Olympia provide a rationale for testing women for BRCA1 and BRCA2, maybe in the future PALB2, even if they don't necessarily meet NCCN criteria. But this would only really apply if they are being considered for PARP inhibitor because they meet eligibility criteria for those trials. The NCCN criteria are still pretty sensitive for BRCA1 and BRCA2, and especially if you combine that with an age cutoff of 60, 65. And since most breast cancer, or at least a very substantial proportion of breast cancer occurs over the age of 65, a policy of testing all breast cancer patients really is not going to pick up many, if any, more BRCA1 and BRCA2 carriers, but will potentially increase the yield of moderate penetrance variants, variants of uncertain clinical utility, and variants of uncertain significance. So for now, I think I would take a look at somebody, if they haven't been tested in the diagnostic setting or the peri-diagnostic setting, and you're thinking about treating them either adjuvantly or for metastatic disease, then you see whether or not they meet the criteria for treatment on those studies. And then if they do, you could consider expanded testing, at least for BRCA1, BRCA2, even if they don't necessarily meet NCCN. So thank you very much for your attention. I apologize for the whirlwind tour, and if there are any questions, be happy to answer them when we get to the discussion a little bit later on this morning.